When we talk about health systems, we often talk about need, demand, and clinical effectiveness. But far less often do we talk about volatility. And yet volatility may be one of the most powerful forces shaping outcomes. The NHS has not experienced smooth, predictable growth. According to analysis from the King's Fund, funding growth has varied dramatically across decades. Some periods saw expansion of over 6% in real terms. Others fell close to 1%. That difference is not marginal. It is structural. It creates unnecessary and endemic system-wide uncertainty. Long-term planning requires predictability. Infrastructure, workforce training, public health prevention programs, and digital transformation, all of which depend on stable capital and revenue flows. When funding becomes uncertain year to year, planning becomes defensive rather than strategic. Managers do not ask, what would improve population health over the next 10 years? They ask, how do I avoid overspending this year? That shift in mindset changes everything. There is also a legal dimension. As budget holders, managers have statutory duties regarding financial control. Overspending is not simply unfortunate. It may carry professional consequences. So uncertainty does not just create inconvenience, it creates personal risk. That risk changes behaviour. Instead of investing in prevention, leaders delay decisions. Instead of redesigning services, they protect core acute capacity. Instead of building resilience, they build buffers. This has measurable effects on public health. Prevention budgets are often the first to be constrained when finances tighten, yet prevention generates savings in longer time horizons. When funding is volatile, long-term prevention becomes politically and financially fragile. Waiting lists provide another illustration. If funding growth slows while demand continues rising, waiting times expand. When waiting lists grow, public trust erodes. When trust erodes, demand for private provision increases. This brings us to mixed systems. In a system with both public and private provision, variability in public funding does not stay contained, it spills over. When NHS waiting times increase, private medical insurance uptake often rises. That may benefit private providers in the short term, but it also shifts workforce patterns. Clinicians may increase private sessions. Public capacity may tighten further. This feedback loop can accelerate inequality. Those who can afford insurance access faster treatment. Those who cannot remain in queues. Funding volatility therefore shapes not only operational efficiency, but equity. Let me emphasize that statement. Inequity is increased by volatility. Isn't that something we should all be concerned about? Now let us widen the lens beyond the UK. In countries such as Nigeria and Kenya, funding variability is often more extreme and more dependent on external donors or fluctuating government revenues. In Nigeria, heavy dependence on oil revenues creates macro-fiscal volatility. When oil prices fall, public spending contracts. Health budgets become unstable. Long-term planning becomes extremely difficult. In Kenya, devolution of health services to county governments has improved local responsiveness in some areas, but also introduced variation in fiscal capacity between counties. This means funding stability differs geographically. In such contexts, volatility does not simply delay elective surgery. It can interrupt vaccine supply chains, salary payments, and infrastructure maintenance. The principle, however, is the same across countries. Uncertainty compresses time horizons. When managers cannot rely on stable funding, they shorten their planning cycles. They prioritize immediate solvency over future resilience. Inside hospitals, this influences recruitment decisions, capital investments, and even ward configuration. If you are uncertain about next year's allocation, you hesitate before expanding staff establishment. You delay major equipment purchases. Why? You may rely more heavily on temporary staffing, which increases costs and reduces continuity. morale is affected. Staff operating within repeated cycles of financial pressure experience stress, frustration, and reduced organizational commitment. When overspend becomes a recurring narrative, leadership credibility can weaken. This is not merely psychological, it affects productivity, sickness absence, and retention. Now consider private medical insurance. If NHS funding growth slows and waiting lists rise, insurers may see increased demand. Premiums may rise in response. Employers may reconsider coverage. The entire ecosystem shifts. So funding variability operates at multiple levels: macroeconomic, organizational, professional, psychological, equity-based. The critical question is not whether variability exists, it always will. The question is how managers anticipate and absorb it. Strong governance requires transparent reporting of potential over- and underspend. It requires scenario planning. It requires clear communication across management structures so that uncertainty is acknowledged rather than denied. Budgetary stability is rarely achieved by optimism. It is achieved by disciplined forecasting, agile reprioritization, and explicit recognition of risk. But here is the uncomfortable part. If we accept that volatility is inevitable, then part of public health leadership is not just delivering services, it is designing systems that are robust under uncertainty. Because unpredictability is not an anomaly, it is a condition of modern governance. Thank you, and I hope to see you again soon.